Hi, good morning. So my topic is how do we use the anterior segment OCT in better management of white cataracts. So we know that the continuous capsulexis poses a challenge in mature and white cataracts. The incidence of incomplete capsulexis is as high as 28.3%. What do we have in our armamentarium right now? We have a Triff and blue dye. We can puncture the anterior capsule, or we can do a two-stage capsulexis. We can do insulin needle-assisted capsule perforation and fluid removal, and we have again the femtolesa capsulexis. It happens because there is an intralenticular pressure which causes the forward and backward arching of the the capsule, in which certain decompression leads to the Argentine flag sign. Now, literature states there are two types of white cataracts: the one with intracapsular fluid and the one without intracapsular fluid. The question is, how do we find out which one has it or not? Looking at these two photos, you can actually not tell which one has intralenticular fluid or not. So my thought was, how do we figure it out? So we started doing. So this is what we get in the end if you don't know about it. So what we used the anterior segment OCT, and to the left you will see that we have all the eyes with mature cataracts which had no fluid, and on the right side you see these fluid pockets as hyperreflected spaces. So that got us to the aim that let's use the anterior segment OCT as a guide to better management of these white cataracts. So we had a prospective intervention study. All the patients were enrolled having white cataracts. Anything with a retinal pathology was excluded. So we made two groups. We had group 1, which had fluid spaces, which is 15 eyes, and group 2 with no fluid spaces. So what is available to us is we have the anterior chamber lens, which is given by these eyes, Series 500, and we can use this wide to wide angle scan, which can generate an image of the lens up to a depth of about 2.9 mm. So in the surgical technique, we used the modified technique described by Figueroa et al. We saw all those cases which had fluid spaces on the left in the OCT, and we used a 30 gauge needle and perforated the anterior capsule and drained all this fluid out. So you can see in the video you can see the nucleus coming right behind that. And in the second group, we had no fluid on the OCT, so directly we just went in and did the capsulexis with the uterata forceps. So this changes a lot of perspective on how to manage it. So phakial emulsification was normal. We used the diet chop technique. Irrigation aspiration was done using a J-shaped cannula. We used OVD to fill the anterior chamber and while implanting the IOL. And we use intracameral oxyfloxacin in all our cases at the end of the surgery. So the patient demography, we had our axial length of these eyes ranging between 19 to 26 mm. We had hyperopes and myopes in the study. The biggest conclusion of this study was that the complete capsulexis success rate goes as high as 86.7%. It's not that you're not going to have complications. The most of the complication we had was a PCR that happened in the end. When it comes to the amount of nuclear density that can be seen, if you have no fluid on the OCT, the nuclear density that is seen on the anterior chamber OCT is about 1.19. With the presence of fluid, you can go a little bit backwards. But the one thing I have to remember, you cannot visualize the posterior capsule, the space, or the posterior capsular fluid is not seen in these cases. So in discussion, we know that intraoperative OCT has been used for clear corneal wound architecture and OCT guided femtolesa surgery, calculation of intraocular lenses, evaluation of the lens AC and angle. Now the pearly white cataracts, they may have no fluid cortex or may have some amount of small fluid, and this small fluid is the cause of the Argentine flag sign. Now with the help of the OCT, you can actually know which cases have it and which don't, and then only do you need to perforate the capsule. In respect to the complications, as noted with the other studies, the complications were much less. In our study, we only had posterior capsular rupture, which happened on table. Of a thing to note, that in one of the eyes in which there was no fluid, when we did the rexes, we actually started seeing fluid coming in. So this was actually happening because there was a posterior capsular fluid, which in turn, there was no complication as such, but we need to keep in mind that. So in conclusion, this technique allows the surgeon a better management of the subcapsular fluid removal, and you can use a 30 gauge needle, a 26 gauge needle, whatever is available to you. The ASOCT helps you determine the presence or absence of these fluid spaces, and then only you need to do the needle removal. It actually decreases the chances of capsular tears. Thank you.